Hello, my name is Jay Mathews. I have the pleasure of talking to you today about acute limb ischemia on behalf of the NCVH Digital Education Series. I'm an endovascular specialist and interventional cardiologist. I'm also the chairman of the NCVH Tampa Bay meeting, director of the cardiac cath lab, structure heart, and the PERT team at Manatee Memorial Hospital, and a partner at Bradenton Cardiology Center in Bradenton, Florida. These are my disclosures. When we look at acute limb presentation, there are some classic findings. They talk about the 6 classic P's of ALI: pain, pallor, poikilothermia, which is essentially a cold limb, pulselessness, and then also some late findings, paresthesia and paralysis, and that reflects ischemic neuropathy and ischemic myonecrosis. At this point, when you have these findings, it's pretty late and associated with high risk of amputation. Time is limb and life, and there's a golden time window of around 6 hours before you have irreversible neuromuscular damage. So the amputation rates are varied, but noted to be around 6% of revascularization is performed within 12 hours of symptom onset. But if you wait over 24 hours, there's a 20% amputation rate. And the mortality rate is very similar to that of acute myocardial infarction, so around 6 to 12% in multiple series. So this is a very important issue and associated with death as well too, if not treated quickly. Now, there are multiple etiologies. The primary etiology for acute limb is a primary thrombotic event, but about 15% of them are also embolic, and of those embolic events, 80% are cardioembolic, so associated with things like atrial fibrillation. But there are also other etiologies as well too: vasculitis, extrinsic compression, spasm, trauma, and whatnot. Now, when you look at these types of patients, the first line in my practice is primarily arterial duplex and also a physical examination. The nice thing about arterial duplex, it's very quickly performed. You can perform it at bedside, either with a point of care ultrasound device or with your vascular lab. It's easy, it's quick, it's cheap, and it tells you exactly what's going on. Second line therapies include CTA. The pro being you get really good anatomic definition. You can see what the aortoiliac bifurcation looks like. You can know about any surgical bypasses and whatnot. And it's also relatively quick. But the problem is you have the contrast load associated with this, the time spent doing that procedure itself. Even though it's a quick study, you're still delaying ultimate care by getting the CT done. And of course, any type of contrast, especially if you're going to give additional contrast for your interventional procedure, there's a risk of renal failure. Now, some centers also like to get MRAs. We do not do this at our site. It does give you excellent anatomic definition, and obviously there isn't the risk of contrast, but there's also the time and the patient discomfort associated with doing a prolonged procedure. And of course, nephrosing, fibrosing dermatopathy in these patients, especially who have chronic kidney disease. So NFD can be a very fatal, very morbid complication of gadolinium contrast. So in general, we try to avoid that type of imaging study in these patients. If we go ahead and look at the acute limb stages, when you look at stage 1, that's a viable limb that's not immediately threatened. These patients have no sensory loss, no motor dysfunction, and the arterial and venous signals are audible. These are patients that you have a little bit more time before you need to go to the cath lab. Now, compare that to a patient who has a stage 3 event. This is irreversible tissue loss, permanent nerve damage, muscle injury. These patients can't move their legs. They have profound anesthesia, and then the Doppler signals are absent. This patient is very likely to end up with an amputation if treatment is not done immediately. Now, when we look at initial treatments, you want to start with heparin, typically, if the patient can get heparinized, to avoid clot propagation or extension. Pain control is very important. These patients are in extreme distress, and that can also increase blood pressure and cause more vasoconstriction sometimes. Perfusion needs to be improved. You can do this in a number of different ways: by keeping the foot dependent, avoiding heel pressure, using warming blankets like a bear hugger can also help promote vasodilatation. Maximizing oxygen. Oxygen is what needs to get to the tissue to prevent necrosis. Now, obviously, correcting hypotension, so giving saline boluses, albumin, and whatnot too, can help improve volume. You really want to try to avoid vasopressors if possible, because that will promote more vasoconstriction. Now, surgical embolectomy, historically speaking, was the mainstay of therapy for acute limb management, and still for many operators is a preferred route. It allows for direct thrombus removal, but the problem is it can be a somewhat morbid procedure depending on the extent of thrombus, and also may result in incomplete thrombus resolution. Many operators who do surgical embolectomy don't do an on-table angiogram afterwards. So if you don't do that, you don't know exactly what clot burden is left behind. Now, catheter-directed thrombolysis is easy to perform. It addresses that microvascular thrombus, but there's also the cost associated with giving lytics and using the catheters. There's also the risk of bleeding associated with lytics, which is around 9% from the CABINET trial, historically speaking. And of course, you have delayed resolution of the thrombus and increased risk of compartment syndrome by pushing off ultimate reperfusion. A compromise is pharmacomechanical thrombectomy, which allows for less thrombolytic use. We'll talk a little bit more about this. So you get lower amounts of infusion time and marination time, and also potentially allows for single session on-table therapy. There's also a lot less bleeding risk, less than 5%, by doing this technique with a lot less lytic and doing the on-table extraction of clot. Now, catheter embolectomy or thrombectomy procedures allows for potentially no usage of lytics and allows for direct thrombus removal. The big issues with catheter-based techniques like this is blood loss and also the time associated with this, but I'll show you some techniques that can be done to improve efficiency in thrombus removal and how to make it a lot more effective. So reperfusion syndrome is something that's very important to recognize, and it's especially associated with prolonged ischemia, late presentation patients. Now, what happens is when ultimately you restore perfusion or reperfusion happens, it causes a cascade of events at the cellular level. So you have the release of all these inflammatory mediators, you get the release of free radicals, you have edema, thrombosis, and inflammation. So the limb becomes red, hot, and swollen. And if this is not recognized and you don't measure circumference of these limbs after you open them up, it can result in compartment syndrome and ultimately limb loss if you don't have emergent fasciotomy done. Now, there have been multiple discussions as to when do you pull the trigger to perform fasciotomy. This is not entirely clear. Many surgeons will perform fasciotomy early in a patient that has presented late to the hospital for ultimate reperfusion. So there is a school of thought that in some patients who have late or delayed presentation should have early fasciotomy performed to prevent the reperfusion syndrome. Many operators will take a wait and see approach, and you can't always predict what is going to result in reperfusion syndrome, but perhaps greater muscle mass, age, obviously length of time before the patient ends up getting reperfused can impact whether or not the patient will ultimately develop this reperfusion syndrome, swelling, and ultimately need a fasciotomy performed. It's definitely not wrong to perform fasciotomy, but there is some morbidity associated with this. But at the end of the day, if the patient loses their limb, that's a much more morbid outcome. So this is what it looks like, and this is when you do upfront fasciotomy to help prevent the swelling of the compartment syndrome. On the left-hand side, you can see that that limb is much less swollen. On the right-hand side, you can see how edematous the legs are and how beefy the muscles are. These muscles are full of water, are swollen, and without fasciotomy would have resulted in muscle death and this extreme morbidity afterwards. So I want to talk about a few different therapies and different types of therapies. We have acoustic pulse therapy. This is the EKOS type device. Comes in multiple working lengths with an ultrasonic generator. There's a new generator that's coming out as well too, and potentially larger catheters down the road. But the ultimate concept behind ultrasonic energy is that the energy or the acoustic pressure thins the fibrin strands, loosens them, and exposes plasminogen receptor sites, allowing for more lytic penetration. By making the clot more permeable, you can get more drug into the clot, and that process continues to propagate. So you can potentially remove a lot more clot or dissolve more clot with a lower amount of lytic. Also, the acoustic pressure forces the lytic to stay within the thrombus that you're affecting. So you don't get as much downstream effect, but there is some downstream lytic that gets into the terminus of the extremities. I do find that this technology works much better when you do establish some outflow because it seems to prevent overheating of the catheters and also allows for the coolant to work effectively. Now, rheolytic therapy is classically the Angiojet device. So you use these high-powered saline jets that create the Venturi effect and allow for maceration of thrombus. It also allows for passive aspiration. So the Angiojet is really not a powered or active aspirator; it's a passive aspirator, but its greatest strength is in maceration. The other thing that you're allowed to do is this power or pulse power spray technique with TPA. So you're able to instill a bunch of thrombolytic within the limb, typically 10 to 20 milligrams of TPA through the affected side with a 50 to 100 cc saline volume. And by doing this, you can wait 30, 40 minutes, allow the lytic to marinate, and then come back with the catheter to macerate and passively aspirate out the thrombus. Typically, the catheters used are the 6 and the 8 French devices. The 8 French device is known as the Zalante device, and is very effective in macerating large thrombus. One thing that you need to be aware of is that all of these patients, especially with long runs, will typically have a blood-tinged urine. This is not hematuria, but it's really myoglobin. And so this is from broken down red cells. So it's important to notify the nursing staff that the blood will be, the urine will be rose-colored or dark. And this is a function of the amount of time you've spent doing maceration with the device. It's important to avoid extremely prolonged run times, especially with the larger device, because there have been reported cases of renal failure requiring dialysis and also cases of pancreatitis. And this is seen more commonly with the much larger device because it's a much more powerful device. So typically I try to keep my run times less than 200 seconds when using this device. Manual aspiration is the mainstay for many operators. The problem is you have limited aspiration power, small bore, typically poor trackability and crossing, and poor efficacy. So you need to do multiple passes to extract out thrombus. This may work well in small vessels, but in larger vessels, it can be quite cumbersome to remove a large volume of clot. This is the reason why powered aspiration has become of interest. If you compare the suction power of a manual aspiration syringe, initially you can get significant vacuum near negative 29 suction, but you have a rapid drop off as blood starts to fill the syringe. So the suction power drops off dramatically with loss of vacuum. If you compare that to powered aspiration, you have ongoing consistent suction as long as you have power to your cath lab and power to your device. So this is a much more effective strategy for removing thrombus without loss of suction power. So I want to talk a little bit about the Indigo system and also the engine pump. This is from Penumbra. Initially, they got into the market with a neuro catheter and also a neural pump system called the Gomco pump. Then they released the Pump Max system in 2013 and started releasing peripheral catheters of various sizes between 2014 and 2015. In 2017, they released the CAT-D catheter, which was used for dialysis purposes. And then in 2018, they released a coronary catheter called the CAT-RX. Now, in 2019, they released the new engine pump, which maximizes aspiration power and is significantly more powerful than the original Pump Max device. And there's actually several reasons why this is. So they integrated the canister into the pump in a fashion where you don't have to use multiple connections and potentially lose suction power. So by taking this canister and plugging it right into the pump, it allows for consistent negative 29 suction within the canister itself. And then you have a single connector that connects to your catheter. The on switch there has 4 lights that surround the circle. When all 4 lights are on, then you know you're getting maximum suction. There's also this integrated clot catcher, which allows you to see visually how much thrombus is being removed. Blood strains through and presents down at the bottom here. This is typically from top to bottom around 1,000 cc's. So if you take a look here, there's this also concept of this vacuum exhaust. This is the button right here. Sometimes with the larger bore catheters, there's problems with foaming that can occur. And then you can have poor visualization of what's going on within the canister itself. By pressing that button, it actually allows you to depressurize the chamber transiently, allowing you to see what's going on. Now, the problem is if you leave your finger on there too, you'll lose suction power. You can see that the lights actually dropped off momentarily, and that's a reflective of depressurization. So you only want to do that transiently so as to allow for more consistent suction throughout the procedure. Now, another things that they changed as well too in the Indigo system is that they changed the flow switch. For those of you that used the older catheters, and this is actually still on the Catheters device, this was a choke point for thrombus, especially with the larger catheters. So a clot would get stuck within the flow switch itself, and then you'd have to take it apart. By going to a dynamic flow switch, they were able to significantly increase the inner diameter of the catheter tubing without having it get caught up within the flow switch itself. So here's the process. You have your canister in place and you have your tubing in place with your flow switch turned off. You've pressed the one-touch on button, and then you get the 4 lights, which allows you to get to maximum suction. So that is a catheter that is now primed. If you start without allowing for full prime, then you may not get maximum suction during the case. And then by moving the catheter, or rather holding the catheter in place and moving the flow switch around, you can put it to a position of comfort afterwards. I'd like to point out in the back of the pump, there's this USB-C device. This is actually for some future technologies that will allow for more efficient clot removal, and also with some of the newer catheters and larger catheters that will be coming down the pipeline. So stay tuned for some new advancements as well too that will utilize this power port. When you look at catheters, size is something that's very important, and people always get frustrated that they're not able to remove a large amount of clot. Well, the aspiration volume and aspiration efficiency is directly related to the radius of the catheter itself. So you can see here, the Angiojet Zalante device, this is our 8 French device, you can see how much the suction power compares, or aspiration volume, suction efficiency compares to, say, the CAT-8, which is an 8 French device, or the CAT-D, which is a shorter 8 French device. So aspiration volume per second is both a function of the radius of the catheter, but also the length of the catheter. So when you have a shorter catheter, which are with a much larger lumen, you're going to get much more efficient suction. When we look at using these devices and comparing catheter-directed therapies, either with catheter-directed thrombolysis versus direct embolectomy, there's a significant cost differential for both the procedure itself and also what the hospital sees. So when we look at, for example, a venous case, and this is applicable also to arterial cases as well too, simply using an embolectomy type device, and perhaps you can use a small volume of TPA, which is relatively inexpensive when you just use 10 milligrams, the total cost is only around $7,000. Compare that to, say, using an EKOS type device. You have a longer infusion. Sometimes this can be 24 to 48 hours or longer. And then you also have the cost of the ICU stay. So overall cost of the system is significantly higher when you use a catheter-directed thrombolysis method or ultrasound-assisted lytic catheters. When you look at reimbursement as well too, the hospital also does significantly better when you try to use thrombectomy. So simply doing TPA administration, the DRG code is significantly less for thrombolysis alone. But if you go in and try to do thrombectomy, mechanical thrombectomy of any type with any of these devices, it could be rheolytic thrombectomy, or it could be catheter embolectomy with Indigo, you'll get significantly more reimbursement and a much higher MCC code. So this is important for hospitals, and it's much more profitable, which we don't try to think about, but it is relevant when you try to do these expensive type procedures. So another important point to discuss is technique. And the reason why a lot of people fail when they're doing ALI work is because they're using smaller catheters. I already mentioned before too that there's a significantly more powerful results with a larger catheter. If you compare the diameter of a CAT-6 versus a CAT-8, so the CAT-6 is the 6 French device, the CAT-8 is the 8 French device, you can see the difference in the OD is 2 versus 2.67 millimeters. So what we try to do is to use the larger catheter if possible. And even though it's 8 French, it's still a much more efficient way to remove thrombus. CAT-8 has 150% more power than CAT-6, so that's the catheter that you want to use, and it's our preferred catheter to use within iliacs and also within the SFA. Below the knee, we'll switch out to the CAT-6 catheter because your tibial vessels are at least 3 millimeters typically, and a 2 millimeter device can fit there quite well. You can take the CAT6 all the way down to the plantar bifurcation in many patients. The extract technique is the primary technique used for very focal thrombus or short runs of thrombus. What you want to do is to take the catheter and sit it on the thrombus for at least 90 seconds, which allows the clot to draw into the catheter itself under the powered suction. After you do this, the clot is corked, and typically you're able to extract this. It's also important to couple this with a sheath that can deflate the valve on the back end or remove the valve. Our preferred catheter is typically the Terumo destination sheath, and the reason why we use that is you can remove the valve on the back end, and then you're able to remove the clot intact. If you try to pull it through, for example, a crosscut valve or whatnot, the thrombus can actually shear off, and then you're going to clot off the catheter, which will require you to remove the entire sheath. That technique is quite cumbersome. Now, an alternate technique, especially when you have massive amounts of thrombus, is to use something called a separator. And this is a wire with a little bead on the end of it covered in a polymer jacket. I'll show some examples of this later on. And this allows you to break up thrombus in a back and forth motion and not allow you to necessarily cork the clot, but break up the thrombus into smaller pieces, which then get aspirated out and pulled into the canister. So this is a quick example. This is a patient that underwent a TEVAR. She was a small lady, and we had, of course, put a very large sheath into the groin. Afterwards, the TEVAR itself went quite well, but the patient had no pulses in her right leg. So I quickly went up and over from contralateral axis, and you can see here we've occluded both the profunda and also the popliteal artery. So with just the CAT6, and I chose CAT6 here because the patient was quite small, and 8 French was going to be problematic in this particular patient. You can see here, even with CAT6, it was still fairly effective. And you can see that we removed actually what looks like tissue. And that, in fact, was tissue. That was intima that denuded off of the iliac. So we were lucky that we didn't have a frank perforation afterwards. And this is just the thrombosed vessel. It came out as a big chunk, and we were able to extract that out very easily. And this whole process took less than 10 minutes, and we were able to rapidly restore flow to this patient without any major complications. That small denuded area did require a little bit of stenting, but ultimately the patient did very well with this. We talk mostly about lower extremity, but upper extremity thrombus is a big problem, especially in patients with atrial fibrillation. This is a case of a patient who was quite elderly, over the age of 85, who presented from the emergency room with an acute cold arm. She had undiagnosed atrial fibrillation, and she was lucky to not have a stroke. But these patients, you always want to suspect that they could have subacute stroke. And I've had cases many years ago before I started doing catheter embolectomy procedures. When we tried to lyse these patients, they presented with hemorrhagic stroke during the lysis process. So you have to be very wary of giving thrombolytics in these patients because they could have subacute stroke that you're not familiar with or aware of. So in this particular case, we went in with an 890 destination sheath, which was part in the axillary artery. And then you can see here we have a thrombus right in the brachial artery. Going in with the CAT8 device, we were able to rapidly extract out this fresh clot. And you can see here it came out essentially in small chunks, but this was done within 5 minutes. So this is a quick run, and the whole case itself was less than 20 minutes. And you can see here, this is our final result, which was excellent, and there was excellent perfusion to the hand as well. This patient actually was able to leave the same day and was discharged on DOACs. Now, this is a different kind of case. This is a subacute arm. This is a patient around 55. She's a long-term smoker. She actually waited 2.5 weeks to come into the hospital. When she did this, she had had motor dysfunction and some numbness as well too. And this was our initial picture, again, using an 890 destination sheath. You can see we have some flow going around here too. Fortunately, she did not have gangrene. This is just presenting as more of a chronic limb ischemia, despite this technically falling under the ALI moniker. So again, we go into the CAT8 device, similar type technique, and clear this out relatively easily. But you can see here now that we have a problem down at the level of the radial and ulnar arteries and the distal brachial. Now, unfortunately, the CAT8 device does not reach this level, and the vessel becomes much smaller. So this is a situation where we can telescope in the Cat6 through the Cat8 and go down much further. And extract is very helpful in here, and I'll show you what that looks like. So you can see here that we have a discrete occlusion in the distal brachial. And then on the left-hand side here too, you can see this dye. And I've sat on this clot for about 90 seconds and I'm drawing it back, and you can see the dye is coming back with the catheter. On the right-hand side, here's the valve from the Terumo destination sheath that's been disconnected. And you can see here, it's clot on a stick. So afterwards, we go from this to this. So an excellent result with complete restoration of perfusion. These are the large chunks from above, and these are the smaller chunks, including that clot on the stick that we were able to fish out from below. And this patient did fairly well. She unfortunately did leave AMA from the hospital because she wanted to go smoke, which was the primary etiology for this failure, which was quite unfortunate because 4 days later she represented again with the same thing, and I had to do the exact same procedure again. This time she was not so lucky and did require a fasciotomy. Fortunately, she has been compliant with anticoagulation and she has never smoked again. I want to highlight this case. This is a case of massive thrombosis. This is an 85-year-old woman who presented with a syncopal fall. She had facial trauma, hematoma. She has had a history of multiple falls in the past, and the CT shows chronic strokes and atrophy. So this is a patient right off the bat that you would not want to do thrombolysis on. So there's a strong possibility that she could end up with a hemorrhagic stroke. The right leg has been cold for 2 to 3 days. This is a patient you also want to think about reperfusion syndrome. And she also has some concerning findings with numbness, coolness, and muscle weakness. With this type of flush occlusion, going up and over from contralateral axis is really not effective. You're not able to cross through here. So one option, of course, is to come from the arm and try to cross through this occlusion. The other option is that you're able to perform a Fogarty type procedure. So a balloon embolectomy procedure with your surgeon certainly would be effective to clean out the thrombus within the iliac. But if we want to avoid that, there's another option. And what I did in this case was with ultrasound, I stuck the thrombus directly and placed the 6 French sheath. And so on the right-hand side here too, you can see I've actually taken the Cat6 catheter and I'm performing the back and forth motion with the separator device. And by doing this, I'm able to clear out a landing zone here. So now I'm able to come up and over with the Cat8 catheter from contralateral access, and then clean out above, and then also clean out the common femoral. Where the sheath is located, we close that site with a Minx device. And so you can see here now we've got pretty clean flow. And then now we have to address the SFA. So we do that with the Cat8 device going all the way down to the distal popliteal artery and get a reasonable result here too. So you have some ischemic vasoconstriction, which will dilate up with nitrates. And then afterwards, you can see we have below the knee thrombus as well. So to address that, I'm going now with the Cat6 catheter. And I think what you will notice is that I have no wire. When you put a wire down, you actually take up lumen. So it's sometimes quite effective to do this without a wire in place. I know that's a difficult concept for some, but the catheters are very atraumatic. These are catheters originally designed to go in the brain, so they don't traumatize the arteries. So if you can avoid using a wire, that's ideal. Of course, if you have dissection or you're worried about your access, you can use a small wire, preferably an 014 wire, to maintain position. But I like to try to avoid using a wire if at all possible to maximize my surface area in contact with the thrombus. So this was a single session type therapy. You can see here we've restored flow to the PT. We've got flow to the entire SFA all the way up to the groin and the iliacs. So this patient actually did well and was actually able to leave the hospital after 48 hours, and she was walking afterwards. She didn't have any long-term dysfunction. I'll show one more case here of massive thrombosis. This is another patient presenting with acute occlusion. This is an interesting patient because she's had multiple operations done by other operators, and you can see she's stented extensively from the iliac all the way down into her tibial vessels. So you can see that there's flow through the internal iliac artery, but the external is thrombosed. So we go in again with the Cat8 device with the separator going back and forth with a rapid motion, which allows you to break up that thrombus readily. So in this case, because there's so much clot, you don't want to use the extract technique primarily because it takes a lot of time. So by doing this, I'm able to restore flow above. And I show this here too. You can see that there's stents all the way across the popliteal, and then this happens. So there's so much suction power that the stent collapses around the catheter. That's okay. That in fact, that is sometimes beneficial because it allows you to approximate the walls to remove the thrombus, but you can't advance the catheter at this point. So this is where you want to crack the TUI a little bit, or even use that depressurization button just to allow you to release the suction so the catheter can be advanced down. And you can see here, we've got a reasonable result here. We've opened flow through the popliteal artery. Now we have thrombus in the infrapopliteal vessels. So when I talk about using a wire, this is a situation where you need to do one. So I've gone through the perineal artery with a Fielder XT wire and then gone through the posterior communicating branch all the way up to PT. And this is the patient's single vessel runoff, so I need to restore flow. So rather than using lytics and dripping it, I took the CATRX catheter, which is an RX device, which is easily able to torque through this tortuosity. And then I was able to clean it out completely. And you can see we've restored flow to the entire posterior artery and the entire foot. The patient did very well with this and was back out of the hospital within 24 hours. So in summary, ALI is both a limb and life-threatening condition. As I mentioned before, too, it has the same mortality as in-hospital acute MI, which is between 6 and 12%. Physical examination is extremely important in trying to risk stratify these patients, and ultrasound can offer rapid assessment. Direct removal of thrombus with endovascular techniques with multiple different devices can offer rapid resolution of symptoms. And sometimes reperfusion syndrome does happen. It may be unavoidable. Early identification of reperfusion syndrome can avoid limb loss and also late fasciotomy and morbidity associated with that. Now, new technologies continue to be developed, which allow for more easy thrombus removal with larger catheters while preventing blood loss and ultimate complications. Thank you.